Hello, my name's Fiona. I'm a pharmacist from Glasgow and I also work for the Liverpool team with the Hep Drug Interaction site. And today I'm coming to talk to you about clinical pharmacology of the directly acting agents. So today we're going to learn about the categorisation of the different drugs. We're going to look at and understand the enzymes and the transporters used. And we're going to look at the issue of how hepatic impairment can affect the choice of directly acting agent that we use. So let's have a look at the approved agents that we have at the moment. We have the NS3 protease inhibitors, we have the NS5A inhibitors, and we have the NS5B inhibitors, which are split into the NUCs and the non-NUCs. Taking a look at the NS3 protease inhibitors, these drugs have a high potency, they have a low barrier to resistance, and they have limited genotype cover. So these drugs are used predominantly just for genotype 1 and 4. Looking back at the start, we started with telaprevir and boceprevir. We then moved forward to cimeprevir, paritaprevir, grazoprevir, and more recently, voxilaprevir and glecaprevir. These drugs have high DDI potential. They're heavily liver metabolized, and when we're looking at drug interactions, these frequently come up as being an issue. Looking at the NS5A inhibitors, these are the drugs that end in as-vir. As a category of drugs, these have high potency, they have a low barrier to resistance, and they have multi-genotype cover. So these drugs cover most, if not all, of the genotypes in each treatment regimen. So what are the NS5A inhibitors? We have declatisvir, ladipasvir, umbitasvir, elbasvir, velpatasvir, and pibrentasvir. And as a class of drugs, these have low to moderate DDI potential. And then finally, we have the NS5B nucleoside inhibitors, and these drugs end in buvir. These have intermediate potency, so perhaps you'd need to use it in combination with another drug. They have a high barrier to resistance, so it can be difficult to get resistance to these. We need to find the S282T. It doesn't hang about for very long, so that makes it a good option. And they have pan-genotypic coverage, so these drugs cover genotype 1 to 6. And the only licensed option for this at the moment is sofosbuvir, and it has a very low DDI potential, and we'll come back to that later. And the non-nucleoside inhibitor that we have licensed at the moment is dasabuvir. Dasabuvir has a low to moderate DDI potential. So these are the two different groups of the NS5B inhibitors. So for the treatment of hepatitis C, all of the directly acting agents, we have to think about drug interaction potential. The enzymes, the CYP450 enzymes play a big part, as do transporter interactions. And if we look at this slide, we can see here that the OATP1B1 transporter, P-glycoprotein and BCRP all have to be taken into account when we're looking at finding a co-medication that we can use with each of the directly acting agents. pH interactions we'll talk about later also play a part. So let's look at each individual DAA that's licensed. So we'll go back to the first protease inhibitor that was licensed. The first once a day one after telaprevir and boceprevir was cimeprevir. And when we talk about interactions, we talk about the victim and the perpetrator. So is cimeprevir the victim of interactions, or can it be the perpetrator? Can it cause drug-drug interactions itself? So as a victim of drug interactions, cimeprevir is metabolized via CYP3A4, which means it's prone to interactions with inhibitors or inducers of cytochrome 3A4. It's also transported by P-glycoprotein and OATP1B1 and 1B3. How can cimeprevir perpetrate interactions? Well, it's a mild CYP3A4 inhibitor. So I think it's important that we understand the difference between mild, moderate and potent interactions. So cimeprevir is only a mild 3A4 inhibitor, so that means where we may get an increase when it's co-administered with CYP3A4 substrates, it's likely not to be, in the most part, clinically significant. However, it depends very much on the co-medication that this is given with. It's also an inhibitor of transporters PGP, OATP and BCRP. So sofosbuvir was the next licensed directly acting agent that came out around 4 or 5 years ago now. And this has little to no metabolism, and the only drug interactions that we should be concerned with sofosbuvir are with BCRP or PGP inhibitors or inducers. So sofosbuvir can be the victim of drug interactions, but as a perpetrator, there aren't anything that we need to worry about. Following on from sofosbuvir was the compound sofosbuvir and ledipasvir, which we know is Harvoni. So we know that sofosbuvir has minimal metabolism, but when you add another drug to this compound, ledipasvir, you have to take into account the effect of both drugs. So ledipasvir is a transporter of BCRP and PGP also, so it's subject to be the victim of the same drug interactions as sofosbuvir, but it can also perpetrate drug interactions this time. So ledipasvir has very mild 3A4 intestinal inhibition and induction. These are unlikely to be clinically significant, but it is a pathway of the metabolism along with UGT1A1. As an inhibitor, ledipasvir can inhibit PGP and BCRP, and the interaction we see with tenofovir, which we'll touch on in other slides, is because of this PGP interaction. Declatisvir was the next licensed directly acting agent, and declatisvir was the first drug for hepatitis C that allowed for dose changes. So the standard dose of 60 milligrams, you could give a 30 milligrams or a 90 milligram dose to allow for drug interactions, and that's because declatisvir is a substrate of CYP3A4. It's also transported by PGP and OCT1, and as a perpetrator of drug interactions, there's not a huge amount that are clinically significant with declatisvir. Again, the transporter interactions come into play. Following on from that, we have 4 separate drugs to think about in the AbbVie combination of paritaprevir, ritonavir, ombitavir and dasabuvir. So 4 different drugs to think about how they're metabolised and transported. And that's really important when we're looking at the overall drug, that we understand how each individual compound is metabolised. So paritaprevir, as a victim of drug interactions, is a substrate of CYP3A4. So that means if it's given in combination with other inhibitors or inducers, concentrations can go up or down. The same with ritonavir and dasabuvir, which is a substrate of CYP2C8. So dasabuvir specific interactions with 2C8 inhibitors do occur because it's a substrate of that enzyme. Similarly with the other drugs, we have to consider transporter interactions. And with paritaprevir and dasabuvir, again, it's the PGP, it's the OATP and it's the BCRP. The biggest issue with this combination is that it's a perpetrator of drug interactions. So paritaprevir, ritonavir, ombitavir and dasabuvir all together, because of the ritonavir in the compound, we have potent CYP3A4 inhibition, and that affects lots and lots of drugs that we give in combination with comorbidities for hepatitis C. Along with the potent CYP3A4 inhibition of ritonavir, we do have inhibition of UGT1A1, which is how drugs like raltegravir are metabolised, 2C8, 2D6, potentially with ritonavir. Now, ritonavir used to be used, as you will know, at high doses in HIV, drug doses of 500, 600 twice daily. We know that CYP2D6 was an issue. It doesn't seem to be a same issue with 100 milligrams, and that's why there's a question mark in the slide, but it's in there just to be aware of. Ombitavir and dasabuvir are also glucuronidated by UGT1A1. So we need to think about all these things when we're looking at other medications given with these compounds. Again, transporter interactions, a lot of the drugs that are not recommended or contraindicated in the license for this drug is because of the effect of transporter interactions. So big increases because of OATP inhibition, PGP inhibition or BCRP. So lots going on with that compound. Next, we move to grisoprevir and elbasvir. This is an NS3 and an NS5A compound by Merck. And grisoprevir and elbasvir are both CYP3A4 substrates. So again, they can be the victim of drug interactions. And they're transported again by similar enzymes that we've seen with other ones. Again, the OAT, the PGP, the BCRP. What about this combination causing drug interactions? So is grisoprevir, elbasvir, can it be the perpetrator of drug interactions? Well, yes, it can be. So grisoprevir is a weak inhibitor of CYP3A4. So that means when it's given in combination with 3A4 substrates, because the inhibition is only weak, it's unlikely in the most cases to be clinically significant. Where we have to think about weak inhibition is with drugs with a narrow therapeutic index. So that perhaps is one where we would see that interaction come into play, but in the most part it's unlikely to be clinically significant. Elbasvir, the NS5A inhibitor, is a weak PGP inhibitor. So again, PGP interactions need to come into play there as well. The next licensed DAA out was sofosbuvir and velpatasvir. So again, we have the presence of the sofosbuvir there, which we know has a good clean drug interaction profile, minimally metabolized. The velpatasvir is added on, and again, we have to think about how the velpatasvir is metabolized. So as a victim of drug interactions, so how other drugs affect the soft velpatasvir or the Epclusa, we can see that velpatasvir is metabolized via CYP2B6, 2C8 and 3A4. So that means if there's any drugs that are significant or potent inhibitors or inducers of these compounds, that we need to take that into account. And it's also transported by BCRP and PGP, again with the OATP this time in addition to the sofosbuvir. What about sofosbuvir and velpatasvir causing drug interactions? Well, again, we do need to think about that again with the transporters and the PGP inhibition, OATP and BCRP. So if we look at the license for sofosbuvir and velpatasvir, and we see that certain co-medications are not allowed, then that's likely because of the transporter interactions and the fact that these drugs are substrates, so can cause and be the victim of transporter interactions via OATP and BCRP. So the two most recent compounds I'm just about to talk about now, sofosbuvir, velpatasvir and voxilaprevir. So if you noticed the last time we spoke about sofosbuvir, velpatasvir, so this is just the addition of a third agent, voxilaprevir, an NS3 inhibitor. So if you have three drugs, you have three different routes of metabolism and transporters to think about. We've already discussed sofosbuvir and velpatasvir, so what does the addition of voxilaprevir bring? Well, we can see that it's a substrate of CYP3A4 and it's transported by the same transporter interactions. What about interactions that it causes? Again, it's not significantly CYP metabolized, but it is transporter interactions again that we need to think about. And the issue with these compounds where you have three different drugs is that potentially you have an additive effect of interactions. So if you have PGP inhibition with velpatasvir and PGP inhibition with voxilaprevir, do you get an enhanced effect? And perhaps we need to do more studies in these areas to see the effects of these, but we do need to take into account BCRP inhibition, PGP and OATP1, and voxilaprevir particularly is a potent BCRP inhibitor, and that's why we see some of the recommendations on the license for that. So the most recently licensed directly acting agent is glecaprevir and pibrentasvir, which is an NS3 inhibitor and NS5A inhibitor from AbbVie. So if we have a look at the charts here to see the routes of metabolism, we can see that both glecaprevir and pibrentasvir are CYP3A4 substrates. So that means we have to be careful if giving in combination with particularly inducing 3A4 drugs that we get suboptimal concentrations. Again, the same transporter interactions that we've previously mentioned, OATP, BCRP and PGP, these drugs are transported via similar routes. And as far as this combination being the perpetrator of interactions, again, the same transporters come into play. So when we do look at the license and we see which drugs aren't recommended, they are, again, similar to with the other ones, largely to do with transporter interactions as opposed to CYP enzymes, because the glecaprevir CYP inhibition of 3A4 is only weak. So again, the large majority of drugs that are 3A4 metabolized are not going to be clinically significant. So now that we've looked at the different routes of metabolism and different transporters used with these directly acting agents, what else do we have to think about when making a recommendation for drug-drug interactions? Well, often our patients have different degrees of hepatic or renal impairment that also comes into play that can be really important when we're helping to select a drug. So if we look at the different classes here, we have the NS3 inhibitors, We have the NS5A inhibitors and the NS5B, which we previously mentioned. And if we have a look at particularly NS3 inhibitors, where we see the most issue with hepatic impairment, and this table splits the drugs into Child's A, Child's B and Child's C. And if you look at the protease inhibitors, you can see the large increase in the area under the curve, particularly with Child's B and more so with Child's C cirrhosis. So it's really important when we're looking at our patients that we understand the underlying liver disease that they might have. And the red shows which combinations are not recommended if this patient has this degree of liver disease. So if our patient has Child's B or Child's C liver disease, we can see that none of the protease inhibitors are recommended, and that's because of that fold change increase that you see with these patients. The NS5A inhibitors don't have the same restrictions, but the umbitosphere and elbosphere we see are in red because these are given in combination with NS3 inhibitors. So you can't give them by themselves. Therefore, because they're all given in combination with an NS3, we can't use these either with Child's B or Child's C liver disease. And similarly with the disabuvir. So the sofosbuvir containing regimens with ledipasvir and velpatasvir are currently the only licensed drugs that we can use if our patient has decompensated liver disease, Child's B or Child's C cirrhosis. So that's really important to remember, that we don't just look at the DDIs, that we also look at the liver disease, and now moving on to whether or not our patient has any renal impairment. So if we look at CKD stage, we can see the progression from 1 to 5 with a CKD stage of 4 and 5 being a eGFR of less than 30. And that's really important when we're choosing a directly acting agent to use with our patient. And we can see here from the guidelines that if our patient has an eGFR of greater than 30, that all directly acting agents are licensed. However, if the eGFR is less than 30, then it's not recommended to use sofosbuvir containing regimens. So why can we not use sofosbuvir in an eGFR of less than 30? Well, this table shows us the data. So if we look at a patient requiring hemodialysis, we can see that it's not so much the sofosbuvir, but the 007 metabolite that accumulates quite substantially. You can see the large increases given 1 hour before and 1 hour after hemodialysis, but also with our patients that are not yet on dialysis but still have that eGFR of less than 30, you have the 451% increase. So whilst there's studies ongoing, this combination is currently not recommended in patients with an eGFR of less than 30. So how do we take all this data that I've just spoken about, the renal impairment, the hepatic impairment, and mix it all together to come up with some interactions? Well, we have to take into account whether or not the enzyme that is interacting is a mild, moderate or potent inhibitor or reducer, and that changes whether or not it's likely to be a clinically significant interaction. So if you have a potent inhibition or a potent induction, you are entirely likely to have a clinically significant interaction. A weak inhibitor tells you that you might have around a 2-fold increase, and in most cases that may not be clinically significant. However, we have to think about the narrow therapeutic index drugs, and a 2-fold or less than 2-fold increase may be entirely significant. So it's about looking at each drug individually to make that assessment. Our job is to look at the harm that giving drug A with drug B is likely to cause. And the difference with hepatitis C is that a lot of our patients have cirrhosis, and we have to remember that these drug interaction studies are often done in healthy subjects. So you're going to have a much more potentiated effect for a drug that's metabolized via the liver if you have a cirrhotic patient, and that's a really important point to remember. One of the things that may be in our benefit with hepatitis C compared to HIV is the period of exposure. So most of these drugs are only given for 8 to 12, maximum 24 weeks. And that gives us the option of thinking about stopping a drug. So for example, if you have a patient on a statin with a statin interaction, With HIV, that's likely to be an interaction for life. However, with hepatitis C, we can think about stopping the statin for the duration of the treatment and just restarting it. But again, that would be a clinical decision looking at the clinical parameters of the patient in front of you. Everything with drug interactions is a risk-benefit decision. Some interactions are entirely unavoidable, and we have to just do the best we can and set up a patient management plan to get that patient through it. And that might be taking additional bloods, taking blood pressure, heart rate, ECGs, but it's important that both the clinician and the patient understands the interaction and what monitoring needs to take place. So in summary, DAAs can be categorised into different groups, but it's NS3 inhibitors that have the highest likelihood for drug-drug interactions. All currently licensed DAAs have enzyme or transporter interactions that we have to consider before starting a patient on treatment, and that the child's Pew status, so whether your patient is child's A, B or C serotic, has an important part to play also when selecting a directly acting agent.